Hi everyone. I hope everyone is doing good in the pandemic. I'm going to talk on current usage of mitral valve assessments by 3D echocardiography. 3D echocardiography is a front runner in many cardiac interventions, whether we talk about intraoperative as well as a cath procedure. Now, in intraoperative, we are mainly concerned about the repair, replacement, and the quantification. And in cath lab, it is useful for valvotomy as well as the replacement of the mitral valve. Carpenter has given a nice nomenclature to the segmental analysis of the anterior and posterior mitral leaflets. We all know that it is A1, A2, A3, and P1, P2, P3. The advantage of this 3D echocardiography that we can have the same segmental analysis from the LA aspect as well as the LV aspect, and assessment from the LV aspect in the same American Society of Echocardiography based guidelines, where the aortic has a 12 o'clock position, and anterior mitral leaflet is at the up, and the PML is down, and the view from the LV to LA is also very important from the apex that I'll come to later on, as well as it gives them some ideas about the assessments of the annulus as well. Very nicely settled step annulus you can see, and aortomitral angle also can be seen very well. Now, Carpenter has given a classifications in stage 1, in type 1, where you have the perforations of the leaflets, which is clearly seen. But what about the type 2, type 3, type 3A, type 3B, where they are saying it is a dynamicity, like hyperdynamics or restrictive dynamics, and then sometimes we are in trouble to differentiate the which is the reason of pathology. And that is very important when you are discussing with the surgeon. Now, if we talk about the degenerative valve disease, again, that's a very important to differentiate the fibroelastic deficiency disease or myxomatous Fibrous disease. Like that is very important where the 3D comes into the play. Like if we start talking about the myxomatous valve, we know that in myxomatous valve, it is a bileaflet prolapse where both the segments are bulging into left atrium with a regurgitation in multiple segments. Even that can be seen very well on the 3D echocardiography. Then what is new we are getting from the 3D echocardiography? That can be seen that in a European journal, very nice article published, that even in the Barlow's disease, if more than 3 sclerosis involved, and if posterior commissure involved, then though it is difficult, but still it is feasible to repair the mitral valve. But if it is more than 3 sclerosis with the anterior commissure involved, it is unlikely that you should not even try or attempt for the repair. In case of degenerative fibroelastic disease, if it is a localized prolapse at the P2 or A2, it is feasible. So we can exactly do the segmental analysis and commissure analysis on the 3D echocardiography, and we can discuss with the surgeon how it can be useful. Like in this case, you can see that it's the posterior commissure involved. Here you can see that the P3, A3 and posterior commissure is very badly bulged and calcified, but the anterior commissure is spared, more than 3 sclerosis with posterior commissure, so it is feasible, though it is difficult valve. But look at in this view that it is a mainly anterior commissure involved, which is posterior commissure is spared, and the rest of the leaflets, even the mild posterior commissure involved, and the rest of the leaflets are not also looking very good. So you can see here, and even by doing the extra mitral valve quantifications analysis software, which also gives an idea about the bench to P1, A1 and P1, particularly the P1 segment is bulging out, and you can discuss with the surgeon to look at the anterior commissure and A1, P1 is badly affected, and probably you will not have the best result. So we can discuss by looking at 3D assessment that whether the surgeon will be able to do it, repair possible or not possible. So that makes a difference between the 2D and 3D. That is segmental analysis and commissure analysis. Now here in the fibroelastic disease, you can see the P2 part is flail, or you can see the cord is ruptured, can nicely be seen in the P2 aspect. But if you get some type of cases where it is not bileaflet prolapse, but you can see that the P2 segment is bulging out, which looks like a myxomatous, though the rest of the segments are never looking like a myxomatous. What could be the reason? Because fibroelastic, when they come to after a long time, and when over a period of time, these prolapsing segment looks like a myxomatous somehow. That has been nicely demonstrated by Adams in his articles in 2008, which he published, that This is the myxomatous changes of the fibroelastic disease. So though it is 2D in looking like it's a myxomatous, but it is a fibroelastic disease that can be nicely differentiated. So we can even encourage the surgeon that, yeah, that is possible repair. And what you need to do is just remove the P2 segments, do the quadrangular, triangular resection, or sometimes they do the commissuroplasty along with that, and they can get away with good results. Post-operative this patient of repair, you can nicely see that the SAM, which is happening, there is systolic anterior motion of the both hip and coapting, going bulging into the alveoli, and you can see very nice anterior jet, directing jet after repair. So we can just go ahead, go back on pump, and then we can advise for the bigger size of the annuloplasty ring, and ultimately result shows a very nice anteromitral leaflet which is touching to the other part of the ring. P3 part also seen very well, and now the coaptation is going up to the level of the annulus, which is not going to the level going down to the alveoli. Many of the times we see this, that anteromitral leaflet bulging to the ring, and there is a significant color jet coming to the because of the A3P3 aspect. Because the A3 segment has gone beyond the level of the ring, annuloplasty ring. So here we can again discuss with the surgeon that there is some problems in the A3P3 area or the commissural area where the surgeon go back, and then he can see, you can see the color onto the, you can see very nice the jet which is coming from the posterior commissure, the A3P3 commissure, and then surgeon they take the alpha, which is called the commissure alpha, and then we can see very nice smiley of the mitral valve annulus, and we can do a very well repair. MR quantification, here on 3D you can see that the color jet is coming from the A3P3 aspects when the anterior part is totally spare, and otherwise it looks very clear, good mitral valve leaflet. But put a color, you can see the single leaflet analysis segment is involved. Now, when we do the segmentation of this, like in this view, you can see that if you go to 2D echocardiography, that is hardly you can see any vena contracta because we are cutting the angles from the anterior aspect. So we face are even P1, but the regurgitation is at the A3P3 level. So definitely we cannot see the vena contracta, and that is the problem where we are not giving the right vena contracta. But in this case, with the Praxis Slice software or the reconstructor software of Echo machine, we can just make a right angle from where the regurgitation is there, and we can make a right plane, and from that plane, the area of interest that we are going more in the deeper plane, and then we can measure the vena contracta, we can measure the pizza, and we can come out with the right quantification of regurgitation. Even with the multiplanar, multi-slicing analysis, we can have a right cut section at that particular vena contracta level, and we can measure the circular vena contracta and the pizza. So this is how we can really measure a good quantification. Even in mitral stenosis, that you can see the structure analysis on the left side, you can see that fibrotic atrium, AML and PML. The right side, you can see the calcific AML, PML. Though on the 2D echocardiography, it looks the same, but here the pathology, the structure is totally different. Suppose this is the case where we want to measure the mitral valve orifice. Now in one plane, the same patient, the same case, it's hardly any opening. In the other plane, you can see the very significant good opening. So here on 3D echocardiography, you can see that both commissures are very, very badly fused. You can see there's very narrow opening. Now, this opening, you can see many significant calcification and fibrotic structures near about you, but we want to measure exactly what is the level of stenotic part. So here again, with the same Praxis Slice or reconstruction software, we can make a very nice perfect plane at the level of mitral valve leaflet opening area, and we measure this planimetry area, and we can come to the right conclusion that what is the area of opening. So even for stenotic lesion, we can get a better idea about the stenosis. If from the orifice area, if you go to the commissural area, and there's very good articles are coming up that apart from the orifice area, it is very important to look for the leaflet and look for the length of the cord. Now you can see the commissures, and if you see the commissures, very nice articles is published in the European journal that they have shown that if the fusion is that at the commissure level only, then they score 1. If it is extended beyond the commissure level, then they give the extra score 1. So on one commissure side, if it is extensive commissure fusion, it is score 2. On both the sides, if it happens like same thing, then total score is 4. So what they suggest that if you want to do the commissurotomy, measure the score on either side. The score, if the score is 2 in any of the commissures, you have to do the commissurotomy till the level of annulus. Or if score is more than 2 in one side and more than and the 2 on the other side, so if the total score is 4, you should never push this patient for balloon mitral valvotomy. So basically, if your total commissural score is more than 2, this patient is not subjected for the OMC, or this patient is not subjected for balloon mitral valvotomy. So these are the patients who should go for the mitral valve replacement. So the commissure fusion, the level of commissure score 1, beyond the commissure again score 1. So 2 on the one side, 2 on the other side. If it is more than 2 total score, then this patient is neither for the OMC or nor for the balloon valve mitrectomy, and they should be subjected for the replacement. Even the look at the anteromitral leaflet, that can nicely be seen on the structural analysis of the mitral valve analysis, that if it is a pliable non-calcific anteromitral leaflet and the mild subvalvular disease and the thin chorda, if the chorda lines from the tip of the papillary muscles to the coaptation area, if it is more than 10 millimeter long, then this is a good valve. If patient's anteromitral leaflet is still pliable, non-calcified, but the subvalvular disease is significantly involved, the cord is thickened and 10 millimeter, less than 10 millimeter, means ultimately still the anteromitral leaflet is preserved, which is non-calcific and pliable, still you can go for the repair. But if the group 3, where there's a significant calcification of the leaflet, anteromitral leaflet particularly, with whatever the length of the cord, these patients are not best for the repair. So for the structural analysis, with the anteromitral leaflet, non-pliable and non-calcified anteromitral leaflet can nicely be seen on the 3D echocardiography, and we can see the repairability of this patient. So basically, you have to see the pliable and non-calcific anteromitral leaflet. In ischemic MR, what is very important? The important aspect is leaflet analysis, which is usually a normal leaflet, where you will see that when patient has significant MR, and if you do the strain, you will find the infra-posterior aspect which is involved, and you can see that this is correlating very well. So in the ischemic MR, both leaflets are totally normal with annular dilatation, and whereas if it is eccentric jet, that is jet coming from the posterior commissure, near the posterior commissure, usually you will have the A3 P3 area and the infra-posterior infralateral aspects which is involved. So even the leaflet assessment is very well possible with 3D echocardiography. It can differentiate also with difference between the scallop and the cleft also, that whether it is extending to the level of annulus, which is called the cleft, or it's not extending to the level of the annulus. Now, if you go back to the cath analysis, and in cath analysis, we can see that you can see that if you can center the eye over the coaptation and the mitral valve, you can see that very restrictive posterior mitral leaflet, but the anteromitral leaflet is overlaid. Now, and you can see that the jet is going more to the posterior medial aspect. Now, these patients have been subjected for the mitral clips. Now, these mitral clips in the cath lab procedures, what is the minimum requirement? What is the minimum requirements for the motion posterior for the mitral clip? That in the cath lab, that their A2P2 segment should have the adequate coaptation size. There should not be significant more than the 1.5 millimeter gap of the coaptation distance between the anterior and posterior mitral leaflet. There has to be a non-calcified non-calcific part of the A2 and P2 segments. The annulus should be at least 4 centimeters square dilated. So these are the criteria which should be fulfilled, which should be fulfilled by the echocardiography. And here, while doing the procedure, you have to see the leaflet structure. The PML should not be restricted. There should be the mobile PML because it's going to the microclip. The arms is going to the grasp to the A2 and P2 from the apex. And here the time comes very important of assessing the mitral from the LV aspect as well as from the LA aspect. Now here you can see that. The very nicely seen the structure. This is a microclip which has opened the arm, and this arm is going to be a grasp to the A2 P2 level. Now, if you put a color flow and you can see the both aspects from the LA aspect and from the LV aspect, you can see the centralizations of the devices. If DIC device is not central and then you make a gradient, so gradient will be different. Now here you can see that regurgitating color is equally from the both aspects looking from the LV side. So pizza or the regurgitation segment is clearly seen. Now if we are putting it and the measure the gradient, it is about 6.4 millimeter mercury gradient. Now again resetting more to the central aspect, and then you measure it, then you may have the gradient difference. Now after having a little more gradient, what it is done that we have resettled the centralization of the microclip segment. You can see that the opening arm is grasping the leaflet is exactly at the A2P2, and that can be nicely seen from the left ventricular aspect as well. So then you measure the gradient. This gradient comes about 4.9, which is a physiological gradient. And here, when you are measuring the gradient, it's very important that you see the heart rate and hemodynamic aspect as well. So after that, you can see that the grasping of the both leaflet is very well. And if you put a color flow, that is significant reduction in the color flow. So in the mitral valve assessment, for the microclips, the post-mitral post-microclip implantation, it is very important role of the intraoperative as well as post-operative 3D aspect. So this is how it is going to be a useful 3D assessment in of mitral valve in the cath lab. So basically, for us, 3D aspects of the mitral valve is useful in the pre-operative for the assessment, for the repairability, intraoperative to discuss with the surgeon, and the post-repair for the assessment, the regurgitation, and the stenotic quantification, as well as in intraoperative cath lab, like in balloon mitral valvotomy for the assessment of the feasibility of the balloon mitral valvotomy by looking at the committers, for the repair, the anterior and posterior mitral leaflet assessment, when you are grasping your leaflet with the microclips and your assessment. So this is how you are going to be take a great help of the perioperative period. So thank you very much and open for the question.